Hello, welcome everybody to our live webinar, Management of Disruptive and Harmful Behavior in Epilepsy and Autism Spectrum Disorder. Thank you for joining us today. My name is Cindy Wright, and I work with the Child Neurology Foundation, and I'll be helping moderate the presentation today. Today's presenters are Drs. Ann Tilton, Nathan Call, and David Dunn. And before we get started with our program, I just want to take a minute to go over a few of the features on the Zoom webinar technology. Immediately following the presentations, there will be a brief question and answer session. And please feel free to submit questions at any time during the presentation by using the Q&A button on your control bar. This is probably on the bottom of your webinar window, but sometimes it appears on top as well. The questions you submit will be seen by today's presenters, but not by all the other webinar participants. And we will be limiting the questions to one per person, just because we have so many people joining us today. We will also be limiting. We'll probably only be able to answer a few of the questions, so we will do our best to answer the most commonly asked questions. When asking questions, we respectfully ask that you do 3 things to help us respond to your questions better and manage any incoming questions. One is to submit your entire question all at the same time and not in pieces. Because we'll be getting so many, it'll be hard to put them back together. We also ask that you provide the minimum amount of information you feel necessary to respond to your question. The lengthy questions can be difficult to understand and for us to respond to. And finally, please keep your questions general in nature. The presenters will not be able to provide medical advice related to your specific situation. So thank you. And at this time, I will turn it over to our first presenter, Dr. Ann Tilton.
Hello. It's a pleasure to be here, and I'm really looking forward to sharing information about our topic today. And what we're going to be talking about, as you know, is managing disruptive and harmful behavior in epilepsy and autism and their spectrum disorder.
Hi, Ann. You're a little hard to hear.
Okay, is this better?
That's perfect.
Okay, well, let me just switch phones real quick. Anyway, so again, it's a pleasure to be here. I am now the past president of the Child Neurology Foundation, but very proud of all the things we've done in the last year. And we presented this at the Child Neurology Society, and we're very excited that all of you are here today. And on the next slide, let's see if we can. I wanted to take a moment to really acknowledge the people who have been pivotal in helping us here. As one of our major partners is the Tuberous Sclerosis Alliance, also the Greenwich Biosciences, along with UCB. And we want to thank them again for making all of this possible, and also the information that we have shared with others. So as we look at really what our purpose is on the next slide, that is that we really would love a world in which all children affected by neurologic disorders reach their full potential. And that really meets the goals of and the vision of the Child Neurology Foundation. And our mission is really to serve as a collaborative center of education and support for caregivers and their children with neurologic conditions. So as we move forward with this, I think it became very clear that we had, as a group, said what questions need to be answered. And one of them that kept rising to the surface had to do with behavior. And as you see in the next slide and the ones that follow, the real question was, how big a problem is behavior and how well is it managed? And it's interesting, both from the physician side and the parent and caregiver side, how the different groups sort of perceive this and how to align them. So what we did was to conduct 2 surveys to learn about behavioral management challenges from professional groups as well as family participants and perspectives. The Child Neurology Society membership sent out a survey to them and received 218 responses, which in fact is a really large response rate. Although there are about 1,000, 1,500, to really have a response rate of that says that this is a question people are interested in. But even more interesting, I think, was the family survey, and they received nearly 2,000 responses. So that really emphasized that families and caregivers also very much see this as an issue that we need to look at how is it best managed. So in the next slide, we can understand a little bit more. What we learned is that behavior is a much bigger problem than child neurologists even realized. Not that they weren't faced with it frequently, but how much it was really pervasive or parts of children's and families' lives. Medication is the other issue. It isn't the only answer to behavioral management. We knew that, of course, but interestingly, there were other more effective areas that could be really looked at. And child neurologists, although they often have to take up these reins and work with this, don't have the training or resources that they need or feel that they need to prescribe the medications required. And they often want to refer to health professionals of mental health specifically, and you'll learn here in a minute why that became quite an obstacle and was perceived as one. So as we look farther into this, on the next slide, what we can see is that behavior and behavioral problems have a profound effect on children and on their families and on other people. And the families really see it quite a bit differently. The overwhelming majority of child neurologists believe that while there's clearly behavioral problems, but few of their patients demonstrate disruptive or truly harmful behaviors. Families see a different picture. As you can see here, 50% reported aggressive outbursts every day to several times a week. 81% outbursts at least once a month. 29% self-harm every day or several times a week. And 53% at least once a month. Only 10% reported no behavioral issues. So as I mentioned that it has a profound effect, and in the next slide you can see that 96% of the families have told us that behavior impacts their interactions or their child's interactions with adults, peers, and family members. It affects overall happiness. The behavior impacts the child's ability to comply with any treatment plan or with a treatment plan that physicians give them. The ability to attend school regularly at 70% is impacted, and behavior impacts the family's ability to even relax at home, which is a major issue since that's often an oasis from other issues. And as we move forward, we can see in the next slide that families tell us that 90% or more, and I'll let you look through this, of their children have difficulty paying attention or mood swings, 80% or more the inflexibility, sleep difficulties, and I imagine some people are nodding yes, impulsivity and anxiety, and 70% or more communication issues, eating disorders, certainly the difficulty with peers, and the well-described overactivity and hyperactivity. In the next slide, we find that child neurologists, that families believe that medication isn't always the most effective. Now, we do know that we have to use medications at times and that they have some efficacy, and we never dreamed it'd be 100%. And behavioral therapy also is often hand in hand. But one of the things that I think that most of us found was really interesting was that the most really effective turned out to be caregiver training. And so we cannot ignore that part of it and assume that medication is only one part. And that raises the issue of where peer support, other training, and the Child Neurology Foundation and similar groups can really be helpful with this. So as the child neurologists face barriers, like we'll see in the next slide, they really have some barriers to referring patients. Mental health professionals are often not available. Insurance is often an issue, and that is in half of the child neurologists reporting. A third of child neurologists report that mental health professionals are not accepting new clients because they already are very much overly subscribed. And half report that they think that families will decline the referral, which is an interesting thing that we'll see in a bit. And so all of these things are barriers to referring our patients. In the next, we will see that the child neurologists also are uncomfortable with a great deal of this because 92% report prescribing behavioral mood medications, but only 48% have true continuing medical education or other formal education in this class of medications. But because of the need, often child neurologists come into that role of prescribing this. 40% also said that sometimes they have to use physical restraint, even in their office. But again, the training has not been there on true techniques for restraint. So there's a need for education for the physicians as well. So where does that take us in the next slide? And that is that child neurologists face barriers to also prescribing medications for behavior. Report is that 40% of child neurologists are very concerned over side effects. 1/3 really are concerned that there are other options out there that they are not aware of that maybe could better serve the patients. And so they're also concerned about the interactions with other medications. So very much would love to refer if someone was available for that or to seek education in that regard. So behavior is actually, as we say, our problem. And child neurologists know the importance of behavior, and 95% says it impacts our ability to even see the patients. And a large majority say it impacts our ability for our patients to actually comply with their treatment plans. So it impacts their care. And caregivers clearly can't do it alone. 50% have reported they don't know how to manage the behavior or have an effective response plan when the child is violent, challenging, or dangerous, which is certainly frightening. And 41% say, who do we turn to? Who do we talk to? So child neurologists actually are well positioned to help, and I think are very much interested in doing so. What was something was people predicted that maybe they wouldn't want to have, or their patients wouldn't want to be referred. It's clear that all families reported they're willing to discuss behavioral issues with the child or general neurologist. So families are very interested in saying, what can we do? This is disrupting our lives. And you can see over a majority also say that child neurologists or general neurologists are the professionals that most often provide treatment for these behavioral issues because of the reasons we mentioned. And 54% said that they are the ones who actually prescribe the medications most often. So what can we do? Well, learn about strategies and listen to colleagues and listen to families. Learn about behavioral therapy options, learn about pharmacologic medication options, and open our minds to brainstorm for other strategies. And training, as we can see here. So all of these things, as we'll see, are really a call to action. You may not be able to control every situation and its outcome, but you can control how you deal with it. You can control your attitude. And so moving forward, that is a way that we would want to really call to action. So with that, I thank you for your attention very much, but the most important things are to follow now, and we have excellent speakers, and so I am going to step back and enjoy it along with you. Thank you.
Thank you, Anne. And also thank you to all the families and professionals that filled out that survey for us, because it really helps drive our direction. So at this time, I'm excited to introduce our next speaker, which is Dr. Nathan Call.
Good afternoon. So thank you all for the opportunity to take part in this webinar. I think that we've had a really good introduction that's talked about the problem and how people are perceiving the problem and their role within that. And I'm going to be speaking a little bit about behavioral approaches to addressing problem behavior in these kinds of individuals. And so if one looks at the literature from even a couple of decades ago, there were many instances of case studies where a behavioral approach could be shown to be really effective for certain individuals for problem behaviors like aggression or self-injury, property destruction, and so on. The problem was that those case studies were often intermittent and couldn't always be replicated. And so even though there were these great stories about how effective some of these behavioral interventions could produce great outcomes, the success seemed to be kind of intermittent. And that's really mirrored in some of the experiences that I have when I'm working with families. And when I talk to families when they first come to our clinic or our service, and we ask them what they've tried in the past, most parents, most caregivers have tried something from a behavioral standpoint, whether that's a reward strategy or something like that. But the other thing that we tend to hear is that the success of those strategies is either short-lived or works sometimes but not other times. And that seems to be just the inconsistency is the pattern that we see more than anything else. And there are some good reasons for why that might be the case that I'm going to talk about on the next slide. And so I want to talk a little bit about just one example. This is a young man. This is a hypothetical young man. I always joke that hypothetical kids are always easy because they always do exactly what they're supposed to illustrate my point. But in this example, we'll just call this young man Tim. We'll say that Tim has autism spectrum disorder, doesn't have a lot of functional communication, and the concern here is that Tim is hitting his parents. Now, like a lot of kids, Tim doesn't always hit his parents in just one situation. He hits his parents in a couple of different situations, and in this case, we'll say that sometimes he hits them when they tell him to turn off the TV, and other times he'll hit them when they tell him that he has to brush his teeth. So I'm going to talk a little bit about how those two things matter on the next slide. So first, before I do that, I want to talk a little bit about a term called topography. And topography in this instance means what the behavior actually looks like. This is how we oftentimes categorize behaviors, and this is how most people think about behavior, is what does the behavior actually look like? What's the form of that particular challenging behavior? When someone comes to a provider, they want to know, what do I do about my child's hitting? What do I do about my child's self-injury? And in those instances, they're talking about the topography of that behavior. And here's an example of just several different sub-topographies of aggression. So aggression can look really, really different depending on the form or the topography. You can have biting or kicking, scratching, hair pulling, throwing things at somebody. Those are all different examples of topographies of aggression. And why that matters is that oftentimes when a layperson or just somebody who is trying to deal with these problem behaviors thinks about what they're going to do to address it from a behavioral standpoint, oftentimes that topography is what they rely on to make decisions about what strategies to try. And we call that a topographically prescribed treatment. Now, unfortunately, topography isn't as relevant for developing a treatment as one might otherwise think. Think about a topographically prescribed treatment can be something like, well, if the child does X, then the parent or the caregiver or someone else needs to do Y. I sometimes say that oftentimes you go out in public and someone is more than willing to comment on your child's problem behavior and they're telling you what to do about your kid's behavior. They're giving you a topographically prescribed treatment. So you're at the store and your child throws a tantrum and someone says something rude to you about how you should be a better parent, and just if you just put that kid in timeout, well, then that would be a topographically prescribed treatment. But there are lots of other examples, and so that can be something like if your child hits, then you should put them in timeout, or if your child bites, then you should do something else. So those would be examples of topographically prescribed treatments. So on the next slide, if we think about how topography matters to our hypothetical child, we can get the next slide. Might have some technical problems. The person who's advancing the slides, if we could just move ahead by one. Are we able to move the slide forward, please? Well, I'll just talk a little bit while they're working on that. So the issue with topography is if we think about our young man Tim, right? Here we go. So Tim, when he hits, remember he hits, if we use a topographically prescribed treatment, we might say to use something like timeout. And there are lots of other behavioral strategies one might contemplate, but if we thought of timeout as just one example in this case, well, a topographically prescribed treatment would say, well, if he hits, then he needs to go to timeout. And if he hits in the first situation, which is when someone tells him to turn off the television, well, that might actually work, right? He might learn over time that, well, when he hits, he doesn't get to continue to watch television. Instead, he has to go to timeout. That's not a preferred place to be. And over time, that behavioral strategy would be expected to work because he's going to learn that hitting doesn't get him what he wants. And in that case, what he wants is more access to television, right? But in the second situation, he hits his parents when they tell him to go brush his teeth. And if they're using that topographically prescribed strategy, what that would mean is that he would go to timeout, right? That's the same thing. Hitting the topography is driving the strategy. So he hits, he should go to timeout. But in that situation, he's learning the exact opposite of what we want him to learn. He's learning, well, when I hit, I don't have to brush my teeth. That's a great outcome. I sometimes think about this as I saw a greeting card a while ago that said all of my childhood punishments are now my favorite things. You know, naps, being sent to my room, these are all things that as an adult I really, really enjoy, but as a kid, you know, that's not the purpose of those behaviors. And so instead, it can be really important to instead think about the behavior functionally. And in this case, what we mean by function is the purpose that the behavior serves for that individual. That means thinking about the reason the behavior occurs. So function in this case sometimes is talked about in terms of a reinforcer, and we think about that the behavior is maintained by a particular consequence. And so a function-based treatment in this situation means that problem behavior that occurs for a particular reason has a particular treatment, and if it occurs for a different reason in another context, it's going to need a different treatment. So this would mean that in Tim's case, hitting that's maintained by access to television should equal timeout, but hitting that's maintained by avoiding or escaping the demand to brush his teeth should result in something else, something like requiring him to brush his teeth faster, making sure that you stand next to him, that he does a really good job so he's not able to escape or avoid that non-preferred task. So that would be the key difference, the key distinction being the function of the behavior driving the particular treatment. And this is part of the reason why we find that oftentimes we get this intermittent success. We hear parents say, well, sometimes this treatment works and sometimes it doesn't. The reason for that is because oftentimes they're using a topographically prescribed system where they're using the same strategy all the time instead of using function to take into account the reason the behavior is occurring for that particular individual and adjusting their strategies accordingly. So if we could see the next slide. All right, so when we talk about function, there are two broad categories of function, and this is a really important point to think about because it really helps to, I think, solidify some of what I'm saying around why knowing the function of the behavior matters. So one broad category of function would be social functions or social reinforcers. These are behaviors that are occurring where the consequence is mediated by somebody else, and that somebody else can be a caregiver, a parent, a teacher, anyone else. And so this oftentimes people think social means attention, but in this case it doesn't necessarily have to be attention. Attention is one example of a type of social reinforcer or social consequence, but it can be something else like a preferred item. Thinking back to Tim, television could be a social reinforcer in this case because the parent has the remote control. The parent can control access to whether he gets it or whether he doesn't. And so that makes it social in the sense that they're the ones who are providing the access. Access to the consequence that serves that function is mediated by somebody else. And that's distinguished from these more automatically maintained behaviors where that's just not the case. Automatically maintained behaviors are behaviors that automatically produce the consequence, hence the name. And so these would be behaviors where in the chain of events between the behavior and that consequence, no one else is involved. These are oftentimes thought of as things like stimulatory behaviors. So a child who engages in some stereotopy because it feels good, or like hand flapping or body rocking, and even some forms of self-injury, things like head banging, have been shown to be maintained by automatic reinforcement in some cases, that there is some just stimulation that's produced by engaging in that behavior. Now, I want to be really, really clear here that that's not always the case. And oftentimes people make assumptions about things like stereotopy and self-injury, and they may assume that stereotopy is always going to be maintained by automatic reinforcement. That is, that it's occurring in order to produce that stimulation or self-injury. And there are lots of instances in which those behaviors were actually maintained by some social consequence, that the individual may have learned that engaging in that behavior, for example, produces a reaction from a caregiver, whether that reaction is attention or giving them something to calm them down, and that access to that preferred thing is actually the function, not the stimulation that's automatically produced. And so this goes back one more time to this idea that the topography is not necessarily going to tell you the function, that you have to do some assessment to identify that instead. Now, it's also important to remember that automatic functions can arise due to certain underlying medical issues. And so, for example, if you have a headache, you may kind of push on your head or even bang your head lightly against something just because it produces a temporary relief from any discomfort or pain that's being experienced. And so it's always important to make sure that any underlying medical issues are evaluated and addressed at the very beginning of treatment. So when it comes to identifying the function of behavior, like I said, there is a process for doing it, and typically that's a term called functional assessment. And functional assessment in this case is an umbrella term that refers to any methodology by which one tries to identify the function of behavior. That can include things like interviews. There are some structured questionnaires that have been evaluated in the past, like the QABF, the questions about behavioral function, the FAST, the motivational assessment scale, and so forth. So there are a lot of these indirect measures where it's based upon asking other people about the potential function. But the gold standard is a form of functional assessment called functional analysis. And this differs from other forms of functional assessment in that it directly manipulates certain aspects of the environment and sets up what we would call analog conditions. These are conditions that are set up to be analogous to the natural environment in some important ways so that they manipulate those key variables that are hypothesized to maintain that problem behavior and testing the function in that way. So for example, if we're hypothesizing that this problem behavior is occurring to access a preferred item, we might set up an analog where we restrict access to that preferred item, and if the problem behavior occurs, we might provide brief access. And then compare the rate of the problem behavior in that condition to a control condition where the child has continuous access to that same preferred item. Some people call this the equivalent of a behavioral allergy test. It's very similar to those tests where they prick your skin with 50 different things and they look for where a reaction occurs. And that's somewhat similar in this case in that it's trying to evoke the behavior and see what is causing that behavior to occur. Now, most of the folks who are going to be qualified to do this type of assessment are board-certified behavior analysts, or BCBAs. But it's really important to know that not all BCBAs are trained to conduct these. And in fact, a minority of BCBAs have ever conducted a functional analysis. And so this is an important skill, not necessarily because every child or every individual who engages in problem behavior needs it, but if somebody has the experience conducting functional analyses, they're going to tend to be more qualified to actually determine whether one is needed or not. And so if you're working with professionals, folks like BCBAs or other folks who have experience doing functional assessment, a good question is, what's your experience with functional analysis? Not because you're necessarily requiring that they have to do that for every individual that they're working with, but knowing that someone has that type of experience is a good indicator that this is someone who has experience working with challenging behavior and developing function-based treatments for those challenging behaviors. So it's a good indicator, and it's a good question to ask, even if it's not necessarily what's going to happen in your particular instance. So if you see the next slide. And this is an example of some data from a functional analysis. So if you look at this, the closed circles represent a control condition. And this is a condition where the child had free access to all of the things that were hypothesized to potentially maintain problem behavior. So this is a condition where the child had free access to attention, free access to preferred items. There were no demands being placed. And what we see is that if you look at those closed circles, they all are right along that x-axis. So there's seeing zero rates of problem behavior. This was aggression and disruption for this child. So that's telling us that when the child has everything that they want, we're not seeing any problem behavior. And that's really important because if the behavior is maintained by automatic reinforcement, that wouldn't necessarily be the case. But if you look at the other symbols, those represent some of these test conditions that I was talking about. So just for example, look at the closed squares. These are the black squares. And this is a condition that was testing for a hypothesis that the problem behavior was maintained by access to a preferred item. So in this condition, a therapist would come over to the child after they had had access to a preferred thing and say, it's time to put this away for a little while. You can't have the iPad for just a little bit. And they would restrict access to that iPad. And then if the problem behavior occurred, they would deliver that, in this case, for 30 seconds, and then repeat that process and say, all right, it's time to take away. If the child gave up the iPad and let the therapist have it, then the therapist just held it for the remainder of that session. These were each about 10 minutes in length. And what you see from these data is that those closed squares, those dark squares, reliably are seeing more problem behavior than in that control condition. And that's what we're looking for when we do an analysis like this, to demonstrate that sure enough that this variable of access to a preferred item really seems to be central to this behavior, and that behavior serves what we would call a tangible function or access to preferred items. That's the function of that child's problem behavior. Now, interestingly, this child, you also see two other data paths that are elevated. These are both triangles, and these are test conditions that are evaluating the role of escape from demands. Two different types of demands in this case. One was an academic task, and one was more of an adaptive skill. And so when presented with this demand, the child engaged in the problem behavior, they would get a 30-second break, and then they would present the demand again. And in this instance, again, we saw problem behavior. So this child's problem behavior serves two functions: access to preferred items and escape from demands. The open squares are an attention condition, where attention was restricted and delivered if problem behavior occurred, and this child never engaged in problem behavior when that was the case. So ruled out an attention function, but ruled in an escape function, escape from demands, and an access to preferred items demand. And that tells us a lot about what treatment needs to look like for this particular child. Next slide. So when it comes to actually developing treatment, there are really 4 elements that are important to include. And these are things that we talk about in our service and my colleagues when we talk about an intervention, that all 4 pieces are really important. The first of these is to include steps to prevent the problem behavior from happening in the first place. When I talk to parents, a lot of the times they're pretty good at identifying how to prevent the problem behavior in a lot of instances. Now, not every instance, or they wouldn't be in my clinic, but oftentimes they're pretty good at figuring out how to make sure that the behavior doesn't occur. And that might mean giving the child free access to the thing that they really care about. I worked with a family that carried 3 iPads everywhere they went because the child, if they restricted it, problem behavior would start to occur. So they had to have one in the child's hand and another on standby in case the battery died, and a third one because at one point he bent an iPad in half, which I didn't know was possible, but he was able to do that. And so they wanted to always make sure that he had that because that was how they were able to prevent the problem behavior. And so while that's not really a great quality of life for that family, it is an important piece of the treatment strategy. It's the thing that we would want parents to do when the problem behavior cannot be allowed to occur. Another example, we had a young woman who would get really, really aggressive when driving in the car and at other times. And what we showed was the function of the behavior for her was to access preferred music. And she really liked gospel music. And so she also got aggressive once when they were driving on the freeway at highway speeds, and she reached at her and tried to grab her father and choke him while he was driving. And that's not necessarily the time to implement a strategy of wait it out, right? That's the time when we say, look, find a playlist of her favorite gospel music and just put it on loop so that it's playing constantly so that we can get through that situation safely. And that's when prevention strategies are most appropriate. But then secondly, it's important to make sure that there are actual interventions in place as well. And these are those strategies that are expected to decrease the probability of the behavior over time through repetition. And oftentimes this involves addressing that function of the behavior, usually through 2 steps, especially when it serves a social function. Part of that means making sure that the behavior never accesses that functional consequence. So if for this young woman, if access to the gospel music is the function, that would mean that during times when we're implementing that intervention, if she's aggressive, she doesn't get access to the music. And that's great. She'll learn over time that aggression doesn't get her what she wants, but it also means that she might be aggressive a lot. So another part of that is usually teaching a communicative alternative, teaching her to be able to request that music instead and do that successfully and use communication and other strategies to access that music, and then gradually teaching her things like when she can have the music and when she can't, being able to wait, delays, and these things all take time. So behavioral interventions are great, but they do take a little while to occur, which is again part of why those prevention strategies are so important. Now, another piece that's really critical is the behavior management strategy. These are those strategies that are really used to acknowledge that even if we're successful with a strategy, some of this behavior may continue to occur from time to time, either because the behavioral intervention is just getting started, or it's produced a big reduction, but it hasn't reduced it to 0. And that means coming up with ways to mitigate the effects so that the behavior isn't really having a negative consequence for the individual and those around them. This might mean, what are we going to do to make sure that even when some of this behavior occurs, we're safe, or we can continue to make progress on things like IEP goals and so forth. And then finally, crisis management is crucial, which is that there are always going to be those unexpected events where you find yourself in a dangerous situation or a situation that can't be managed safely. And that means doing what is needed in order to just end that situation as quickly as possible. Oftentimes, this means doing the exact opposite of a behavioral intervention. Remember, I said in the case of the gospel music, that might mean never giving her gospel music when she's aggressive. But in a crisis management strategy, if we're in a really dangerous situation, like driving in a car at freeway speed, and that young woman actually got loose on the freeway at one point. Dad pulled over and she opened the door and was running away around on the freeway. Turn on the gospel music just to get her in the car and get her calm and be able to get back to a safe situation. One of the real keys when we talk about a crisis management strategy, though, is that one only gets to call it a crisis one time. What I find too often is when I go into a school or work with a family and they say, Well, we are using our crisis management strategy to deal with the same thing over and over and over again. That stops being a crisis. At that point, we really need to have a long-term strategy to deal with that situation so it's not reaching that crisis state every time, because a crisis management strategy oftentimes means doing the opposite of a behavioral intervention, and over the long term, that's going to just perpetuate the problem. So these are really 4 strategies, and each one of these I could spend hours talking about each of these, and I really apologize that we only have a brief amount of time to just touch on these, but it's important that if you're working with any kind of behavioral professional, that they're really making sure that they're checking all of these boxes, that there is something in place in each one of these areas so that if one of these is missing, then the full arsenal is not really being deployed, and it's not realistic for that family in order to be as successful as they otherwise need to be. Can we get the next slide? And so the takeaway message, again, from what I'm presenting here today is first that really understanding problem behavior from the perspective of the individual, that is knowing what its function is really the key to developing a behavioral treatment, and that oftentimes means doing a really thorough functional assessment. There are lots of professionals out there who have training in doing some of these things, but they're not all necessarily experienced in doing these with the kind of rigor that we need, and so that's something to really ask about and make sure that whoever you're working with has that type of experience. And then lastly, this middle bullet point, that good behavioral treatment plans are going to address all phases of need: prevention, management, behavioral interventions, and crisis management. And with that, I think those are my comments for you here today, and I'm going to pass the torch.
Thank you, Dr. Call. I know that some people are wishing they could get into your office. I know I would. But for next, we're going to turn it over to Dr. Dunn, and he is going to talk to us a bit about medication. That's a big topic for us.
Yes, thank you. I'm David Dunn. I'm a child and adolescent psychiatrist at Indiana University and also a child neurologist. And what I'm going to be talking to you today about is what kind of medications might be helpful. So if I go to my first slide, the goal really here is to give you an update on what medicines might be helpful and to try to ask 4 questions. The first question is just, do medicines help? And obviously, if I'm about to spend 20 minutes, the answer there is going to be yes, but with some caveats. And so the next question is, what problems really will improve with medication? So we need to think about that. Third is, which medicines are most likely to work? There are a lot of medications out there that are being used, and some are much more effective than others. And so we want to pick out the medicine that's most likely to be helpful. And then the final question is, well, what's going to go wrong? There are adverse effects from almost all of our medicines. If you take aspirin, it's going to cause an upset stomach for some people. And for the stronger medicines that we're going to be using, we're going to have to worry about potential adverse effects that may be significant. So on the next slide, the reason we're talking about autism is that there's so many things that go along with autism. Kids with autism often struggle with intellectual disability. They have difficulty with learning. Many of the children with autism are going to have problems with seizures, and a number of the kids with autism have additional symptoms as well. Things like tuberous sclerosis and Fragile X, just multiple other problems that may be causing the autism, causing the intellectual disability, and causing the seizures. And kids with autism often have a variety of behavior problems. Aggression, hyperactivity, anxiety, and sleep disruptions are some of the ones that we're going to address. So on the next slide, the first question is okay, so do medicines work? The answer is yes, they work, but you really need to use them in conjunction with both education and behavior therapy. By themselves, they can be effective, but they're going to work a lot better if you combine them with education and with good behavior modification. The second thing you need to be doing is really identifying which symptoms may respond to medication. Things like irritability, aggression, this will respond to medication. Kids that have problems with inattention, poor concentration, hyperactivity, and impulsivity, yes, there are medicines that may be effective. The anxious child that has obsessional behaviors, compulsive behaviors, that has depression, those may respond, and sleep disturbances may respond as well. What you're going to notice on this list is I have not said that speech is going to get better. I've not said that learning ability is going to get better with medication. And social skills may or may not improve with medication. If a child's having difficulty relating to others because they get too anxious and too upset around people, or because they're becoming too aggressive, yes, it may help, but it doesn't improve the social skills of a child that's just not interested in playing with others. So watch for those things. If possible, when we're using medicine, we try to get by with using just one medication, and we want to use those drugs that have been proven to be effective in good double-blind placebo-controlled trials. On the next slide, these are the medicines that have different levels of evidence. So there's pretty good evidence in children with autism for using some of the antipsychotic medicines. Old drugs like haloperidol that we don't use much anymore are effective. Newer drugs like risperidone or Risperdal and aripiprazole or Abilify have been shown to be effective in reducing some of the aggressive behaviors, the hyperactivity in children with autism in good randomized double-blind placebo-controlled trials. There's fair evidence out there for treating some of the ADHD-like problems that occur in children with autism. Drugs like methylphenidate, which is the whole Ritalin group of agents, drugs like guanfacine and atomoxetine, which is Strattera, have also been shown to be effective for some children with autism plus problems with attention. Now, there's only minimal evidence or conflicting evidence for a lot of the other drugs, the medications that we normally use to treat anxiety and depression. Drugs like fluoxetine, which is Prozac, citalopram, which is Celexa, or escitalopram, which is Lexapro, buspirone. These drugs have worked in some cases, but not all, and so it's hard to prove that they're really effective. Some of the mood stabilizers, drugs like valproic acid or lamotrigine, have been used, and again, minimal evidence for how effective they are. And then olanzapine, which is one of the antipsychotics, amantadine and naltrexone, which have been used for aggressive behaviors and self-injurious behaviors, sometimes work, but with real limitations. So on the next slide, what might we use? If you start off thinking about autism and aggression, the child that's getting into fights, that's destructive of property, that's hitting other people, the first thing we're going to do is look for those environmental triggers, and if we can find those, we can try to make some changes in behavior. We also should be looking to see if this aggressive behavior is being driven by either depression or anxiety. The child that strikes out because he's frightened and fearful, we need to be treating the anxiety, not the aggression. If it seems to be strictly aggression and not triggered by other problems, then think about monotherapy using either risperidone or Abilify, aripiprazole. In good trials, these drugs have reduced irritability, hyperactivity, and repetitive behaviors. There are side effects that we're going to talk about later, weight gain and sleepiness. There are some other options as well. Olanzapine occasionally works. Occasionally using a drug like risperidone and aripiprazole plus either clonidine or atomoxetine can be beneficial as well. On the next slide, for the children that have autism and a lot of hyperactivity and impulsivity, we use the same kind of approach that we would use for treating ADHD. So stimulant medications. Stimulant medications for children with ADHD work about 90% of the time. But for kids with autism, they're not that effective, but they will work about 50% of the time. In children with ADHD, we have to stop the medications about 5 to 10% of the time, but in kids with autism, it gets up to 18 to 20%. We have to discontinue the medications because of adverse effects, particularly irritability. Other drugs that can work, guanfacine or the extended release form, particularly, or Intuniv is the trade name for it, caused a reduction in hyperactivity in about half of the kids versus only 13% that received placebo. Atomoxetine works in about 1 child out of 5 with autism spectrum disorder. And the improvement, though, will continue over a course of time. So those are reasonable choices for treating hyperactivity and impulsivity. Other options might be going back to the antipsychotics like risperidone or aripiprazole, or using clonidine, or medication that's similar to guanfacine. On the next slide, I talk a little bit about anxiety and repetitive behaviors. Here we have to use some of the agents that maybe have not been as effective, but typically you can start with a drug like fluoxetine, which is Prozac. It has been shown to be minimally effective, at least, in some of these anxious and repetitive behaviors. Other drugs that may be effective include citalopram, sertraline, which is Zoloft, and buspirone. They seem to be more effective in kids that are not as severely affected with their autism. And there may be some reduction in these repetitive behaviors if you used, going back to risperidone and aripiprazole. Next slide, excuse me. For the child with autism, sleep is often a major problem. They have disrupted sleep, they have trouble settling to sleep, they wake up in the middle of the night, they get up early in the morning, they may wander about the house and get into dangerous situations like putting a pot on a stove and then walking off without turning off the gas. And so we want to watch for that. Polysomnography does find that children with autism have disrupted REM sleep, which is when dreams occur, and they also have REM sleep behavior disorder. We know, too, that children with autism often have difficulties with secretion of melatonin. Melatonin is a chemical produced by the pineal gland in the brain that helps people settle and go to sleep. And so a first option may be to use melatonin, an addition of melatonin about 20 minutes before bedtime. Other drugs that can work are the alpha-adrenergic agents like clonidine or guanfacine, occasionally antidepressants like trazodone, or maybe some of the non-benzodiazepines as well. Next paragraph. For kids that are aggressive without autism spectrum disorder, again, we do the same thing of looking for medical, environmental triggers, looking for other psychiatric conditions, and if we find those, treat those first. But if we don't find anything, basically we start with behavioral therapy, and then if necessary, add on medications. And so in the next slide, I'll tell you about just one study. This was a study that started out by using behavior therapy and adding on methylphenidate, one of the stimulants, and found that it was effective both in kids that had ADHD and also kids that had aggressive, disruptive behaviors without ADHD. The kids that didn't respond to that, what they put them on next was either placebo or risperidone, and they found that risperidone caused moderate improvement compared to placebo. So that's a good sign for us as well. Next paragraph. Epilepsy and challenging behaviors. Kids with epilepsy are certainly at an increased risk for both behavior problems and learning difficulties. They're often due to the same underlying conditions that cause the seizures. But we also know that medications that we use to treat seizures can make behavior and cognition either better or worse, so we need to watch for that. Next slide. When we're treating children with autism and epilepsy, we really don't need to make any major changes in our standard treatment for autism. And we don't have to make any changes in the drugs that we would use to be treating the epilepsy, except we try to watch out for the drugs that may cause some side effects. Next slide. These are the psychotropic drugs that may cause more problems with seizures. And you'll see at the very top that there are 3 antipsychotics, clozapine, olanzapine, and quetiapine, that may double or more your risk for developing seizures in response to medication. Most of the other antipsychotics, the drugs like risperidone and aripiprazole, don't seem to cause problems. A standardized incident ratio of 1 means no effect. Bupropion, which is a drug used to treat depression, can cause seizures occasionally, but all of the other antidepressants seem to improve seizure control. The standard incidence ratio is down below 1. The one exception is a drug called clomipramine, which we don't use much anymore. It can significantly increase the risk of seizures. Next slide. There are certain adverse effects of drugs that we use to treat seizures that we need to watch out for, particularly in kids that have underlying behavior problems. The drugs that have had the most in the way of adverse effects on behavior have been perampanel, topiramate, levetiracetam, and clobazam. And so we want to be careful about using those. We can also negatively affect attention and concentration by using drugs like phenobarbital, sodium valproate, lacosamide, topiramate, and zonisamide. On the next slide, if we have problems with either ADHD or aggression in kids with seizures, we use basically the same medicines we would normally use for ADHD, but we avoid bupropion because it can make seizures worse. And we watch out for attention and aggression as secondary effects of the anti-epileptic drugs. And we may want to change the treatment of the seizures. New slide. For kids that have ADHD plus epilepsy, basically what we've found now is that the standard medicines like Ritalin, methylphenidate, does not lower seizure threshold. Amphetamines like Adderall and Vyvanse and atomoxetine, which is Strattera, probably are effective, but there's less data. Next slide. One of the things we're going to always be watching out for is what are the possible adverse effects. And so if we go to our next slide, these are the things we have to watch out for. Weight gain, metabolic syndrome, which is the emergence of diabetes, elevated prolactin, which can cause breast development in boys, prolongation of the QT interval, which sets kids up for cardiac problems, heart problems, and then EPS, which is extrapyramidal side effects, stiffness, shakiness, a variety of other problems. Next slide. So here's the problem with weight gain. We know that the drugs that are most likely to cause trouble are clozapine and olanzapine, but there's also a moderate risk from risperidone and a little bit lower risk with aripiprazole. But all of the medicines that we use can push up weight for a lot of kids. We have to watch by monitoring weight both at baseline and progressively at 1 month, 2 months, 3 months, and then quarterly. We usually watch growth. We watch blood pressure, blood sugar. We do that at baseline at 3 months and then every year. And we watch lipids, cholesterol and triglycerides, both at baseline and at 3 months, and then at least every 5 years afterwards. The extrapyramidal syndromes, and that's things like shakiness, stiffness. Drug-induced Parkinsonism is probably highest with Geodon, ziprasidone, and aripiprazole, which is Abilify. A little bit less of a problem with risperidone and olanzapine, and not much of a problem with quetiapine, which is Seroquel. The treatment-emergent dyskinesias are usually highest with olanzapine and ziprasidone, and if you really push up the doses of risperidone, you can cause trouble. But fortunately, akathisia, which is a restlessness due to these medicines, is pretty rare in kids. If you add the antipsychotics to stimulants, you increase the risk, though. Next slide. Drug-induced QTC prolongation, that's the heart problems we worry about, are most commonly associated with some drugs that we don't use anymore. And so you only have a mild risk with quetiapine, ziprasidone, which are used. Most of the others are relatively safe. You have to watch out particularly for kids that have trouble metabolizing the agents or for kids that have electrolyte imbalance. Next slide. The adverse effects of the stimulants are mostly just annoying. Headaches, stomach aches, decreased appetite, and trouble falling asleep. If you stop the medicine, they'll go away. For preschool kids particularly, they get cranky, irritable, and sad, and so we have to stop the stimulants in those cases. And much less common are problems like increased blood pressure and heart rate, tics, skin picking and nail biting, and decrease in growth. And then very rare side effects of stimulants can be hallucinations or mania. Next slide. A last medicine I want to mention for you, because I get so many questions about it, is CBD in all of its various forms. There is a specific medication using CBD for seizures, and it's been effective. CBD has also been used for spasticity, pain, and now is getting used sometimes for sleep anxiety and aggression. The biggest problem that we have is that the data is not there, with the exception of spasticity and seizures. And so we just don't know. Also, we have problems with the over-the-counter preparations. We don't always know exactly how much CBD is present in any of these preparations, and so you may be getting more or less than you expect. Nevertheless, let me just tell you about two trials. Both of them are from Israel. One found that there was a decrease in irritability and rage attacks, self-injurious behavior, and hyperactivity, and about 2/3 of the kids, somewhere in the range of 5 to 10%, though, got worse. A second study, again, found decreased rage, restlessness, agitation, and 80 to 90%, with, again, 10% getting worse. So this drug is one to keep in mind, but be very, very careful about. Next slide is for me to say thank you for listening and to let you know that, number one, I think medications can be helpful. You have to identify the problem that you're going to be treating, and basically that's going to be irritability, hyperactivity, anxiety, depression, or sleep problems. And the medicines that work, I've gone through. Think about risperidone and aripiprazole or Abilify. Those are going to be good drugs for a lot of these kids. And finally, watch out for all of the side effects, because weight gain and sleepiness may be major problems. Thank you.
Thank you, Dr. Dunn. That was really helpful and informative. I have a couple questions here. I welcome others to add some as well. The first question I have is for Dr. Call, and I think we all know that there's a limit to access of behavior therapists in general, let alone that ones who are really trained in some of the behavior analysis you recommended. And I was just wondering if you had recommendations, and some of our parents asked, on what they can do to analyze and help manage the behavior on their own while they're waiting to get into someone.
Sure. I think, one of the things that I find is that, while I described functional analysis as a really good, important tool that's considered the gold standard, not every child needs that. I really want to be clear that what I was referring to is the fact that oftentimes finding a professional who has experience conducting that type of assessment or that type of analysis is a good indicator that they know what they're doing when it comes to treating problem behavior, even if they're not using that for every kid. But I also know that there's a lot of great ways to try to identify the function that can be much simpler than that. One of the things that I will often suggest is just to ask a handful of pointed questions, things like, are there times that the behavior occurs reliably? Or are there times that the behavior never occurs? Looking at those two different types of situations can say a lot. So hearing a parent say, this kid never engages in problem behavior when he's got his iPad or when she's listening to gospel music, that tells me something about, well, at least that child seems to be pretty calm in that situation. It may be because they have what they want, and when that's restricted, the problem behavior is more likely to occur. Another question that can be really helpful when I talk to caregivers is, what are some things that could reliably cause that behavior to occur? What's the one thing I could do that I could flip a switch and that would almost every time cause the problem behavior to occur? And a lot of parents are pretty good at identifying what that might be, because they've spent most of their waking hours trying to make sure that thing doesn't happen. And so they're pretty able to identify that. And that, too, can tell us a lot about the likely function of the behavior. And then lastly, asking the question about, what is your child trying to say with their behavior? Again, a lot of parents are pretty good at figuring that out, and they have their ideas about, my kid's trying to tell me something, and they just don't have the communication, or it's harder to communicate effectively, or they just are using behavior to communicate what it is that they're trying to say. And so especially for kids who are less verbal, that can be a really important thing. Now, there are some more structured measures. There's things like some structured questionnaires that can be used as well, and I mentioned a few of those. The QABF is one, the FAST or FAST is another, and the MAS, the Motivational Assessment Scale, is a third. So those are questionnaires that can get at some of that same information.
Thank you. Another question is, if a child is on one of the medications, and this is for Dr. Dunn, that has mental evidence, or if the family believes it's causing side effects, how do you recommend they approach their doctor to discuss other options?
Yeah, that's really important. And I think what we are aiming for is really collaborative, because we want parents and physicians to be talking together about what's going to work and what's not going to work. You know, I've given you a list of medications that I think have good evidence that they may be effective, but they're not going to work for all children. Some kids are just not going to respond to them, and some are going to have such side effects that they need to get off. Parents need to be able to go into their doctor informed and say, yep, you've tried this, but these are the problems that are occurring. Either do you have a way to fix the side effect, or do we need to go off the medication? Some of the side effects we may be able to treat. So the child that has a significant increased appetite, let's say in response to risperidone, we may be able to make modifications in diet, in exercise that may help out. For other children, we may wind up saying, well, it just isn't going to work. We've got too many side effects and we need to shift to something else. But be very definite and upfront with your doctor that this is a collaborative approach. Parents are the ones that are living with the child day in and day out. The physician's going to be seeing a child once a month, once every 3 months, maybe once a year. And so children often look very different in the office. They can be quiet, calm, and answer questions or sit quietly in the corner, but we don't get to see what the real behavior is. And so it's important for parents to let physicians know exactly what is going on and what's working and what's not.
Great, thank you. It's just after 3. I'm going to take one more question. This one is talking about doing an assessment in a school setting where they only look at a child in that setting for a few minutes. And, you know, the question is really what is the correct duration to observe, and who should be doing it, and should it be happening in home and at school? That's for you, Dr. Call.
Yeah, so lots of assessments, functional assessments get conducted in schools. It's oftentimes a required element of a behavior intervention plan that's part of a school's response to a child who is engaging in problem behavior. And again, there are different formats of functional assessment. There are those questionnaires that I talked about and others, but if it's an observation-based assessment, and that can be really 2 formats. There's what's called a descriptive assessment, where you're not manipulating anything, you're just kind of watching to see if the behavior is correlated with anything like presentation of demands or something like that. And then there's another category that's the functional analysis I was talking about. It would be really challenging to do either one of those any justice in a few minutes. There are things like a brief functional analysis, and that's an area where I've done some work in the past. But even what's considered to be a very brief functional analysis requires at least 90 minutes to conduct. And often those are conducted in more clinical settings where you've got really tight control and you can move through things really efficiently. And so I don't know that it would be possible to do a very thorough functional assessment or one of those descriptive assessments in just a few minutes. And I would expect that maybe the expectation would be to ask folks to spend a little bit more time in order to really understand the function of the behavior.
Asking the school is also important for medication, I'd say. We usually send out a questionnaire to teachers before we start a medication. And then again, after the child's been on the medication for 2 to 4 weeks, we send a follow-up question to teachers to see, is it helping out in school? Is it affecting his learning? That's important information.
Thank you. We have so many great questions, and I wish we had time to get to them all. Unfortunately, we do not. But I do, and as a general policy, the Child Neurology Foundation always encourages families to speak with their medical teams, ask questions. We also have a family empowerment program where we can connect you with other families that may be able to help you. They also don't offer medical advice, but they understand what you're going through. So please reach out to us if you have information on that. And on behalf of the Child Neurology Foundation and all our partners, I want to thank each of you for your participation in today's events. We really appreciate our speakers making time for us. And we hope the information presented is helpful. I know I did. And we will be posting a recording of this event online, and we'll email all of our participants that registered with a link so you can catch it again and share it with others, and that'll be available within the next few days. When I close this window, there's going to be a survey that will pop up, and we hope you'll respond to the questions so we can continue to improve our programs and make sure we're meeting your needs. So thank you again, and we wish you all the best. Thank you.
Thank you. Thanks.